Hi, everybody. So thank you for the opportunity to present about this important topic today. And thank you all who have joined remotely to be part of this conversation. Next slide. We know that there have been many important efforts to increase access to IUD insertion, which has been essential given the importance of this method and all of the barriers to use that people face. Next slide. However, we have been lacking in efforts to preserve access to IUD discontinuation, and the barriers to IUD removal are not yet fully understood. Earlier this year, we published a study investigating access to IUD removal appointments using a mystery caller methodology. We called clinics in 10 cities across the US and found that only 61% could offer an appointment for IUD removal. While the appointments themselves were pretty timely, at least 17% required an additional visit for removal, with 40% not able to say if an additional appointment would be needed. While 40% could not offer any self-pay cost information over the phone, the ones that did had a median cost of $262, with a range of $50 to over $1,000. So this study highlighted several barriers to IUD removal access. Those that could not offer an IUD removal appointment, even though they offered IUD removal, cited that they can only remove them for their own patients or only if they had inserted the device in the first place. While the visits were essentially timely, they seemed to be scheduled as preventive care visits and not as urgent or same-day visits, which we expect would have been available for other urgent concerns. Next slide. So while we know that even when patients can access and afford IUD removal visits, that providers are another obstacle to IUD removal. Our previous work about IUD removal focused on the patients' and providers' perspectives about IUD removal discussions. I do want to acknowledge that my remaining slides do have a lot of rich qualitative data that we don't have adequate time to go through individually, but I'll instead go through and summarize our findings about each topic. In this study, patients told us how some providers resisted IUD removal. Reassurance about symptoms was seen by some patients as resisting removal. Some patients talked about tension and conflict when discussing removal with their providers, and some patients believed that resistance to removal was because their provider cared about them and their reproductive goals. Next slide. Our findings were consistent with findings from Jenny Higgins and colleagues, who also found that young people perceived resistance to IUD removal. Also, Leslie Hogart and colleagues documented similar resistance to implant removal as well. Next slide, please. Now, when we interviewed physicians, they essentially confirmed what the patients had said. They reported that they favored IUD continuation whenever possible, and that they encouraged continuation if they felt that patients would go along with it. They also confirmed that when encouraging continuation, it was because they believed it was in the best interest of their patient, and that they sometimes struggled between respecting autonomy and doing what they thought was best for the patient. They also reported that IUD removal felt personal to them, especially if they had provided it in the first place. Next slide. Now, knowing about the barriers to IUD removal, we went on to ask patients and providers their opinions about IUD self-removal. While patients were mostly concerned about safety, the providers in our sample were not concerned about safety. Other than this difference, patients and providers were pretty well aligned in their perspectives, being concerned about the provider not being in the loop about the patient's contraceptive or reproductive plans, and being concerned about the possibility of hasty removal as well as coerced removal if self-removal was an option. Next slide. Now, our current project, which I'll spend the rest of my time on, sought to find out about the perspectives about self-removal, not from people coming into the office for removal, but instead people considering or attempting self-removal outside of the healthcare system. In order to find them, we looked to the internet, initially casting a wide net and then focusing our analysis on specifically what people had said in internet forums. With this data set, we asked the questions of why people considered self-removal, how they went about attempting self-removal, and what happens when they do. Next slide. In terms of why, our first theme focused on the need for removal in general, and this was, unsurprisingly, either because of symptoms or in order to try to conceive. Symptoms did include a pretty wide range of systemic symptoms, with or without the more typical symptoms that we would expect, such as cramping and bleeding. And when those were cited, it was often more severe than we would expect. Next slide. Our second theme was about the inaccessibility of provider removal. People often reported a cost that was unacceptable to them, especially in comparison to the cost of the insertion or in comparison to the simplicity of the removal procedure. People also reported that the appointment itself was unavailable or not timely enough, especially given the severity of their symptoms. And lastly, people also cited what our previous research had demonstrated, that providers themselves were another barrier to IUD removal. Next slide. Our third theme was about why people thought that self-removal would be okay for them. People typically referenced the forums themselves and about how they thought it would be okay for them since they had read so many posts about successful removals. They also referenced that they got the information about how to self-remove from the forums as well. And less commonly, people talked about getting an okay from a healthcare provider. Next slide. Now, looking at why people attempt self-removal does give us a few strategies for improving access to IUD removal in general. It shows us the barriers to provider and removal in terms of cost, appointment availability, and provider resistance to removal. And it shows us how, if people are armed with reassurance that self-removal is okay and have access to advice about how to do it, they may be willing to do it when unable to access their providers. So while we're talking today, my recommendation is for us to consider as a community how to increase access to provider removal, as well as at the same time working on improving acceptability and feasibility of self-removal. Next slide. Great. So now for the how and what happens. The data from this next section has not yet been published, and I want to give credit to my former fellow, Samantha Stimmel, for taking the lead on this part of the project. When we looked at what people reported about their experience with successful removals, they overwhelmingly called the process quick, easy, and painless. They often compared removal to taking out a tampon, as well as talked about their symptoms from the IUD going away quickly after removal. I do want to highlight here that no one reported anything bad happening as a result of their self-removal attempts. I do want to acknowledge that this study was not designed to look at safety. But also, we know that the internet is flooded with IUD horror stories that are completely out of proportion to actual complications. So this is something for us to think about. Next slide. When people posted about unsuccessful removals, it was all about the inability to find the strings or to grasp the strings. We only came across one person who reported stopping the removal because of bleeding, although she later posted that she successfully removed it herself later. No one talked about any hospitalizations or surgeries resulting from self-removal attempts. Next slide. Now, successful self-removers talked about attempting removal during menses or after an orgasm. They talked about a variety of positions, including lying down, sitting on the toilet, squatting, or rarely propping up one leg. Next slide. Most successful self-removers talked about using fingers, a fingernail, or a rubber glove, or having a partner use these strategies for the removal. Some people talked about using instruments such as tweezers, forceps, or pliers, and a few people talked about using an instrument to visualize the cervix prior to the removal, although this was pretty uncommon. Next slide. Now, importantly, people identified when it would be okay to self-remove in comparison to when provider removal or assessment would be necessary. Specifically, they had advised other self-removers to stop if meeting resistance or if the self-removal attempt was painful. Next slide. And other than asking for technical advice, people who were considering self-removal asked questions about self-removal care, which often focused on contraception post-removal, fertility post-removal, and symptoms to expect after the removal. Next slide. So self-removal stories in our data set either describe self-removal as quick, easy, and painless, or they describe difficulty finding or grasping the string. In 381 pages of self-removal conversation, no one talked about any complications from self-removal. Of course, these data are limited by what people posted online voluntarily, and we had no way to verify their reports. Our data provides guidance that can support self-removal, including advice about how to do it with a variety of techniques, what symptoms are normal, and what symptoms require an assessment by a provider. It also tells us what questions people have to give us the opportunity to provide some anticipatory guidance about what to expect during and after, as well as resources for family planning post-removal. Now, we're working with the Reproductive Health Access Project to create such a resource, which will be available online as a patient handout. And I know that there are other organizations working on similar resources as well.